Welcome to AETCM, the Emergency Medicine Channel. Sir.
Myself, Dr. Naveen Mohan, HOD of Emergency Medicine at AIIMS Kochi.
Myself, Naveen, second year PG.
Myself, Dr. Shreya, first year PG.
I am Dr. Evin, first year PG.
Dr. Krishna, second year PG.
Today we are going to discuss regarding a 48-year-old female patient who was brought to ER in an agitated state. So we have received a 48-year-old female to the ER.
So the topic is acute behavioral disturbance.
Acute behavioral disturbance, as per AETCM guidelines. We received a 48-year-old female who was in a violent, out-of-control state and who was having continuous loud outbursts. So we have received in the ER. In such cases of an agitated patient, initially the patient cannot be triaged because the patient is violent. So we use this scale called as sedation assessment tool score, sedation assessment SAT score. So in which we have a grading of +3 ranging till 0 to -3, depending upon the responsiveness and the speech. So +3 is given when the patient is combative, violent, or out of control, and if the patient is having any loud outbursts of speech. +2 is when the patient is anxious and agitated, and patient is having some intermittent outbursts. +1 is when the patient is restless or anxious, and the patient is a hyper talkative or normal speech. And 0 is patient is calm, cooperative, and patient is speaking normally. -1 score is given when patient is asleep but arouses if the name is called, arouses to sound. And speech-wise is the patient is slurring or prominent slowing of speech is there. -2 is when patient has response to physical stimulation. And -3 is when patient is not responsive to stimulation and there is no speech. So this is the scale of agitation bar sedation. So depending upon this, right now we get the score as 3 as the patient who arrived was violent and is having continuous loud outbursts of speech. So in such patients who are grade +2 or +3 as per the scale, the AETCM guidelines suggest that we need to give an immediate tranquilizer or a sedation dosage, which is parenteral. The ideal choice in emergency departments would be giving ketamine 4 mg per kg IM dosing. Other option is a droperidol, which is usually unavailable in Indian setup. Droperidol dose is 5 to 10 mg IM dosing is available. So in this case, the patient on arrival was, as it is +3 as per the scale, we had to give ketamine 4 mg per kg IM dosing. Next, coming to such cases of ABD disorders.
So basically any acute behavioral disturbance arriving at the emergency department, you assess the SATs scoring. If the SAT scoring is 2 or 3, as per the
guideline,
then you'll have to straight away go to the IM approach using either ketamine or droperidol.
Yes.
Dose for ketamine is
4 mg per kg IM.
And droperidol
5 to 10 mg
IM. It's not per kg.
It's not per kg.
So 2 options. But if it is, the score is not 2 or 3, if it is less than 2 or 3,
we have a set of approach management. Initial management.
The thing is, if the agitation is so severe that the patient is a threat to the environment or to others, or if the patient has got no mental capacity, then you go ahead with these things. But if the patient has got a mental capacity, that is, if the patient is able to understand, retain, weigh, and communicate whatever things are told to her, then you can go ahead with the
initial approach would be that we have to assess the risk of the patient. That is the SAT scoring which we did, and then next would be using verbal de-escalation.
Verbal de-escalation. In your AETCM exam, they often keep asking the same question for the part 2 intermediate exam, or even for the FRCM SBA exam. They often keep asking what is the first step in management of this thing, verbal de-escalation.
Regarding
all other options will also be given, ketamine, droperidol, verbal de-escalation, environmental de-escalation, these things will be given.
Initially would be the verbal de-escalation. The main components which are involved in the verbal de-escalation is, first we need to see there is a respect to the personal space. We need to identify the exits and also stay out of the reach of the patient's arm. Second would be the doctor should not be provocative, like the hand should be visible to the patient all the time. Next, establish the verbal contact. We should avoid multiple staff talking to the patient, and introduce yourself, explain why you are there and what are we supposed to do. That's like. Next, be concise. We should use only short sentences and give some time to understand, and repetition may be needed here. And identify the wants and feelings. What is the expectation, and empathize with the patient, what he's suffering, or he or she's suffering from. And we have to listen closely, use clarifying statement, whatever the history giving, use like clarifying statements, yes or no, repeatedly asking clarity. And next, we need to set clear limits, informing the patient as a matter of fact and not as a threat. And we have to offer choices and optimism. And next is a debrief the patient and the staff. So these are the domains by which we can do a verbal de-escalation.
This becomes important when you're doing the OSCE part, the Markham OSCE or the FARCAM OSCE. You may get situations where the patient is fully agitated, walking. You'll be in a room, the patient will be walking here and there, totally agitated, saying some irrelevant things, and it is an clear case of acute behavioral disturbance. So it's mainly a psychiatric station. So in that case, you'll have to
follow
address
these
all these aspects. These domains will be checked.
Next step would be environmental de-escalation. The environmental de-escalation contains of these points, like the management must be dedicated, if such severe agitated patients are coming, there should be a space to manage them. Next, there should be adequate exits so that staff can exit without getting trapped by the patient. Next, doors should be opening outwards, and the room should be quiet with low stimulus, not too warm. And there should be the absence of equipment or furniture that can be used as a potential weapon by the patient. And constantly it should be observable, and staff able to signal need for additional support easily. These are all the points.
Basically, scene safety.
Scene safety
is what you mean. So for verbal de-escalation followed by environmental de-escalation.
That followed will be the rapid tranquilization or the sedation. Now, in this rapid tranquilization or sedation is supposed to be parenterally given only in those patients who lack the capacity to refuse the treatment and are non-compliant, or the second, the patients who pose a danger to themselves or others and they have no any further clear treatment plan. In such cases, parenterally we can give. And if the score is +2 or +3 as discussed earlier, we can give the IM parenteral.
As per the SATS scoring system.
SATS scoring system. The options of sedative agents are oral or parenteral. And regarding parenteral, we have the main thing ketamine, which can be delivered intramuscularly itself. If the IV cannulation is not feasible, we can give an IM. If it is possible, then we have to give IV.
Cannula in situ, straight away give
IV.
If not IM.
And as seen by the cases, high rates of intubation after ketamine administration can be seen. If it is given pre-hospitally, if ketamine is given, high rates of intubation can be seen.
So all your necessary equipments for intubation and mechanical ventilation, crash intubation, everything should be ready. Yes. Whenever you give these kind of drugs.
Sedative drugs.
Okay.
And also in the clinical context of severe ABD, the dissociative effect of the ketamine will have to reduce the adrenergic features. And thus the sympathomimetic effects of ketamine are unlikely to cause any adverse consequences. The dissociative effect of the ketamine will help the patients get agitation to control majorly. So that is the use of using ketamine in such patients. And other drug is the droperidol, which
ketamine will be combined with midazolam or?
We can, but as of the it's ketamine initially loaded with ketamine. Maintenance we do with the benzodiazepines.
Okay. So ketamine plus midazolam you give for induction. For intubation.
Yes, sir.
To prevent emergence phenomenon. Here, as per this guideline, ABD is straight away we give ketamine only.
And then after, to maintain that sedation, we load with the...
Once you knock out the patient, you then go for like maintenance of sedation. For that you give benzodiazepines.
And regarding the droperidol, it has fewer adverse effects than lorazepam or midazolam, but the major concern for droperidol is the QTC prolongation. And it is a less suitable option if a patient is already taking antipsychotic medications. Next, coming to the other agent is the midazolam.
Even for head injury,
Ketamine
can be given as per this guide. Recommendations say that you can give because ketamine will cause a raised ICP.
Yes, sir.
But that you will come to know only after doing CT. But here, as per this guideline, you can give ketamine IM. Okay.
Regarding the agents for rapid early control, as we discussed, first agent would be the ketamine 4 mg per kg IM dosing, or we can use droperidol 5 to 10 mg IM. Next, higher concentrations will be like in IM dosing, higher concentrations will be required as compared to IV dosings. And if ketamine or droperidol are unavailable, then we can go with the agents like midazolam 5 to 10 mg can be given, or lorazepam 4 mg IM can be given, or we can use haloperidol of 5 mg IM. And haloperidol is better used in...
Repeat the doses.
Midazolam 5 to 10 mg IM, lorazepam 4 mg IM, haloperidol 5 mg IM, or it can be used in combination with lorazepam of 2 mg IM, 5 plus 2.
Haloperidol is same as Serenase. Normally we have a practice to give Serenase Phenergan. Serenase 5 mg, Phenergan 12.5 mg. But as per this guideline, what it says, Serenase 5 mg
plus
that means 5 mg
haloperidol 5 mg plus 2 mg lorazepam.
2 mg lorazepam. As per this guideline.
And these large volume injections may need to be given at various sites rather than giving at one site. And intravenous sedation is easier to titrate as compared to IM sedation. And we need to consider critical care support if first doses of this full sedation is given, higher doses are being given, then we need to consider further critical care support. We cannot discharge immediately. Next, after the initial dose of rapid sedation is given, then we need to maintain the agitation, for which we need to start with the infusions. Diazepam can be titrated at 0.3 mg per kg IV, and lorazepam 0.03 mg per kg can be titrated. Apart from that, we can use
0.3 mg for diazepam, 0.03 mg for lorazepam.
And haloperidol also can be used for titration. We can give 2.5 mg IM or 2 mg oral depending upon the necessity. Olanzapine can also be used, that is 5 to 10 mg IM or oral. Depending upon the necessity, it can be repeated to maximum 2 times in 24 hours. But in cases where we are suspecting serotonin toxicity, we can use chlorpromazine 25 to 50 mg IM dose can be given along with the benzodiazepines.
That is a question for MCQ will get. So if you are suspecting serotonin toxicity, what is the additional features of what
serotonin toxicity features we can say we can identify with the help of severe psychosis or hyperthermia will be significantly present.
The scenario will be mentioned in such a way that patient has got all these things. So what is the next drug of choice?
Maintenance for the sedation maintenance, we can use chlorpromazine. Apart from that, benzodiazepines are the choice if the patient is presented with the withdrawal from alcohol or sedative drugs. And benzodiazepines usually they worsen the delirium and cause prolonged and excessive sedation in elderly patients. So we need to avoid in elderly patients. The haloperidol and olanzapine most important side effect is the QT prolongation or arrhythmias. So continuous cardiac monitoring should be done. Apart from that, haloperidol is also or droperidol is contraindicated in Parkinsonism or Lewy body dementia disease. If the patient is a known case of such, haloperidol should not be given to them.
That is also one MCQ. Patient with Lewy body dementia presenting this also. So what all things drugs cannot be given? Questions can be framed in that.
Haloperidol should not be. And next, these are the primary required management for the patient. Once the patient is sedated or the agitation is subsided, then we can continue with our normal ER approach of ABCDE and taking the vitals, adjuvants for the required the same, and then taking the history. Regarding this patient who had presented 2 years,
So for this, basically summarizing, patient came, you did the agitated patient, you did the SATS scoring system, and afterwards
decided to give IM parenteral ketamine.
Yeah, either parenteral ketamine or droperidol, or
Depending on the score, if it
depending
is
on
a
the
lesser
SAT
score,
scoring, you decide whether if it's 2 or 3, parenteral ketamine or droperidol. If it is not 2 or 3,
then we can start with verbal de-escalation.
Verbal de-escalation followed by environmental de-escalation, followed by mental health assessment.
And also there's another option of restrainment of the patient. But there are certain guidelines for the restrainment. Ideally, the restrainment should be done if healthcare staff has been injured, or if the appropriate support is not available from the healthcare colleagues to sufficiently withhold the patient, or when there is a risk of serious injury or damage and safety is compromised. In such grave situations, only restrainment is advised. Also, if a patient is restrained, it should not be a prolonged restrainment. Early removal of the restraint is preferred.
As soon as rapid tranquilization is done, restraint should be removed. So environmental de-escalation followed by mental health assessment. Then you can decide
mental
whether
capacity.
to give mental capacity, and then we will decide whether oral sedation agents should be given or the other one. So,
then continuous sedation for the infusion.
Then rapid tranquilization should be followed by that with any of these approaches, and it should be followed by maintenance of sedation. Okay.
After that,
you move on and go ahead with the normal routine primary survey, as that addressing all the A, B, C, D, E, and the predisposing
factors. Actually, patients who are presenting to ED with complaints of acute behavioral disorders, usual potential factors leading to them, most common is the substance intoxication or previous mental health condition is the most primary. Other causes can be substance withdrawal, or patient is in serotonin syndrome, hypoxia, hypoglycemia.
Hypoxia is very important. Patient will be very much agitated, so address that first.
And next, even electrolyte disturbances, sepsis, head injury, anticholinergic syndrome, neuroleptic malignant syndrome, thyroid storm, heat stroke, and seizures. These all can be associated.
So after rapid tranquilization only you address all these.
We try to, as usual, try to find out the causes of the agitation.
Okay.
These are the most common causes of agitation, so we need to rule out these things. Apart from that, for special population, like if patient is a frail or old patient, better reduce the dosing of the sedation, start with half the dosing. That is
That's all. So this will be a short note. Acute behavioral disturbance can come as a short note. So be ready with all these points. Okay. Thank you.
okay.